So thank you very much for the kind introduction. It's an honor and a pleasure to be invited to present in this meeting, and it's an honor to follow Francesco. Now I will move a little bit to meningiomas, and all of you are aware of the now very well and quite old grading of extent of removal, grade 1 to 4 by Donald Simpson. We know we tried to make a complete resection of a meningioma, but looking a little bit on how well we do, we published some years ago a true 25-year-old follow-up of parasagittal meningiomas, and of course with a 10-year follow-up we saw that there was a huge difference between grade 1 to grade 3 and grade 4 to 5 in recurrence rates. So it really had made a lot of meaning to use this grading. But when following the patients longer, we found that when we thought we had made a complete resection, that Simpson grading 1 to 2, we found that almost 40% of the patients still recurred, and which means that 2/3 of the recurrences when we thought we had been radical appeared after more than 10 years follow-up. So of course this shows that Simpson grading correlated very well with 10-year recurrence, and it probably then correlates with a risk of leaving tumor behind rather than risk of recurrence. And because we saw that there was a clear problem to achieve really radical Simpson grade 1 removal, and in a later publication where we looked more into what we could achieve, we actually sent the resection margins from the dura and from the sinus for separate histological analysis, and we found that when we thought we had done a Simpson grade 1 removal, there was still tumor behind in more than half of all patients. There were free margins only in 42%. So shows that Simpson grade 1 is not necessarily radical, and that the resection margins may carry very relevant information, which is not very strange, because if we leave brain tumors for a second and think of systemic cancers, systemic oncological treatments are dependent on dichotomized extent of resection and analysis of resection margins. So if there is no residual tumor cell, one might think that there is no risk of recurrence, while if there is presence of residual tumor cells, the recurrence of the risk of recurrence is dependent on the volume of the residual cells, how many cells, and the biology of them, which suggests that maybe we should think in terms of extent of resection and grading of extent for resection by direct criteria instead of the indirect criteria we use today. What we use today, if we look at the IANO guidelines, they suggest either Simpson grading, which goes from the gross total resection of tumor with or without dealing with a tumor origin, which are grade 1 to 3, through to a partial resection or just biopsy. If we compare this to York and RTOG criteria, which are dependent on so-called objective criteria and imaging, that's not very sensitive, because grade 1 to 3 are all graded as gross total removal, grade 4 as subtotal. But we should remember that grade 4, if we do surgery, we may see that we leave tumor behind and say it is grade 4. This tumor may be invisible on postoperative MRI. So I think there are huge problems with basing grading on MRI imaging. So what we have today is, for extent of resection, is either Simpson grading, which is dependent on subjective evaluation by the surgeon and thus has no traceability, or we have MRI criteria, which lacks specificity, lacks sensitivity. And another thing, if we use MRI criteria for grading resection, I think we end up in another problem, because the grading of extent of resection is normative. And if the norm is to achieve MRI criteria, we may risk of leaving a lot of tumor behind, visible or invisible, if we compare to Simpson grading. And again, I think, why not use direct criteria such as histology and some other kind of imaging? So we have started to implement a different way of grading extent of resection. We use surgical biopsies, where we, for all patients, try to take biopsies after resection of a tumor from 4 places on the resection margin. And in addition, if there is some area where we think tissue looks strange, we think we have removed a tumor, we call that an area of doubt, and we take another biopsy from there. And we use modern imaging, modern histopathology, where we can use specific markers for meningioma, and we use immunohistochemistry for somatostatin type 2 receptors and for EMA. So the first part of Copenhagen grading is including the histopathology of resection margins. And we can grade this as either 1 or 0. If we find a tumor behind, such as we do here, we have a postoperative imaging where we do not see any tumor on the MRI, but we have microscopic evidence of residual tumor cells in the resection margins. So we wouldn't consider this complete removal. This is a Copenhagen grade 1 and 0. But there is still the problem of hidden locations, and as which would be good to look at with imaging, but MRI is not good enough. Low specificity because of scar and reactive fibrosis, and of course the small residual cannot be seen. And for this, people have started using imaging, DOTATOC imaging, which is based on recognizing somatostatin type 2 receptors. Somatostatin type 2 receptors are expressed in almost all meningiomas, and it is a specific marker. An example here is shown where we have postoperative MRI with no visible meningioma behind, and with DOTATOC imaging, we can see meningioma cells. So the second part of Copenhagen grading, again, could be 0 or could be 1, if there is visible tumor on DOTATOC PET imaging. And then, of course, if there is visible tumor, one has the option of going back in, or to follow up, or to use single-dose radiosurgery. So we think that the Copenhagen grading for extent of resection of meningiomas is technically feasible, it's traceable, and it's reproducible. We have implemented this in Copenhagen since last December, and we now treat all patients this way. I think it's traceable and allows standardized clinical research. And if we look back on one of the examples for research that we think could be and should be and needs to be done, I said that if we have a small piece of tumor behind, we could either follow it or we could treat it with radiosurgery. Now, we have published previously here that it appears from retrospective series that the end result will be better if we treat the residual radiosurgically directly as we detect the residual. But this needs to be tested prospectively, and a very good basis for such a study is definition of the residual by Copenhagen grade. Another thing is the issue of Copenhagen grading when we know there are some tumor cells behind, but we cannot see them, which is the Copenhagen grading 100. Again, what should we do to these? Some kind of adjuvant treatment, maybe fractionated radiation. Unfortunately, we already know that fractionated radiation isn't as good as it should be, and one could think of something else, maybe a radiopeptide therapy, which is also a very interesting treatment. So based on Copenhagen grading, we would have a proposal that we first try to stratify extent of resection by the direct criteria we use in Copenhagen grading. That's histopathology, and it's Dotatok PET imaging. We would use biological markers to stratify the growth rate and also need for additional therapies, but also allow to stratify follow-up. And then maybe plan trials for targeted follow-up for RCT for Copenhagen grade 0 and 1 for either Simpson grade 4 gamma directly versus wait and scan and radiosurgery if it grows. Another RCT one could do for Copenhagen grading grade 10 for radiopeptide therapy, for example. So my last slide is that we propose the new grading system for meningioma resection. This is a technical note which is authored from 5 different centers, 4 different countries, trying to implement this grading, and we could then use it for traceable extent of resection, standardization, and also use that as part of stratification for what may happen to the tumors by incorporating the tumor biology. We can see here how Ki67 expression, for example, is not necessarily a marker for risk of recurrence, but primarily a marker of time to recurrence. If you have a high Ki67 IF, the recurrences will come early. If it's low, they will come late. We can use TERT promoter mutation, we have seen as an independent predictor. Gene expression differentiates beautifully between RNA of more or less malignant tumors. So our proposal is to try to use this kind of approach with direct criteria for extent of resection. Thank you.